Hello Namibia, and welcome back to yet another session here at the Government Information Center. This time around, still for an almost information sharing session. This time around, we are discussing the understanding of cervical cancer, and we will delve on the backgrounds, the burden, as well as the interventions. Now, to help expound more on the topic, I am joined in the studio by a team of well-versed professionals from the Ministry of Health, one, and the other one from the private sector. On my immediate left, I am joined by Dr. Laina Iyambo. She is a clinical oncologist with the Ministry of Health and Social Services. And then next to her, I am, of course, joined by Dr. Cornelia Ndifon. She is a GP and director at Sterling Medical Practice. Ladies, good morning once again, and welcome to the Government Information Center.
Thank you very much. Good morning, Helene. Good morning, audience.
All right. Now, to set the scene, Dr. Iyambo, I'd like to start with you. Could you kindly share a snapshot of the current burden of cervical cancer globally and on the Namibian context, and how Namibia then compares to these trends? Because we know that Namibia carries a disproportionately high burden. What does the numbers then reveal about the gravity of this disease in the Namibian context?
Thank you, Helene, for that important question to start our discussion. The burden of cervical cancer in Namibia is quite significant. For a disease that is otherwise preventable, early detectable, and curable, we're still seeing quite a lot of cervical cancer, more often in their advanced stage. So for a population of 3 million, the cases that we are seeing are quite high. Mm-hmm. And the statistics that we have from the World Health Organization as per the year 2022, Namibia recorded 350 new cases of cervical cancer and 203 deaths from cervical cancer. That, simply put, will mean that more than 50% of the people diagnosed with cervical cancer will die from cervical cancer. And that means almost every 2 days we are losing a woman to cervical cancer. If we compare that to the global statistics, globally, cervical cancer is the fourth most common disease, with 660,000 cases recorded in 2022 and 350,000 deaths in the same year. Now, when it comes to Namibia being this part of Africa, it's almost like up to 94% of people diagnosed die from the disease. And so when I say cervical cancer is one of the most common diseases, or rather cancers in Namibia, it's actually the second in women after breast cancer.
All right. All right. Dr. Ndifon.
Yes.
Now, when we look more closely at who is affected by this disease, it appears that young, undereducated women in poorer countries bear the brunt of this disease. Why is this the case? And then also, what factors make them more vulnerable to cervical cancer?
Thank you so much. The question itself gives us the answer. Yeah, being young and uneducated woman simply says that you are not able to, one, determine information, like seek for information about health, because you cannot read, and in some cases are not able to write. So when people cannot read, even if you keep a piece of information right at their face, and most times we are communicating in a foreign language, which is English, they are unable to pick it up and read, let alone understand. Okay? Then they are uneducated because culturally women have been given out to marriage or relationships as children. When they don't have any education, and that is when they should go to school, but they are deprived of education and given out in marriage. Education raises somebody's self-esteem, and so you kind of have some form of importance attached to yourself, and you are interested in knowing, okay, and seeking information so that you want to stay healthy and achieve a lot more. But they don't have this ability. And therefore, health decision depends on their master, the man who is in charge of their lives. And they really don't have anything. Being uneducated and being poor translates to living maybe in a slum in some cases, and also in the village. What do we find with slums and villages is that access to health care is limited.
Very limited.
Yes. So there are two ways. The government is unable to spread health infrastructure closest to the people. On the other side, from the patient or client perspective, because of being poor, because of being uneducated, then they don't have access to ready funds to pay their way to look for help. Okay? So you might find that somebody is in a remote area, for example.
Right.
So being in a remote area or hard to reach area implies that means of transportation, for example, are limited, and transportation fare is not readily available to
Let
those
alone.
people because they are poor, because they are uneducated. You will not find them a lot in the city.
Absolutely.
And then the government, like I said, has not been able to build, let's say, even enough health posts to get closer to those people. So that question of being uneducated, it means a lot of things. It means not being able to read. It means we have also delivered information in a language that they don't understand.
So communication
Yes,
barrier.
it means they are just preoccupied with running a family, and because they didn't have education, the self-esteem is low. They depend on somebody to tell them to go to the hospital, tell them to, give them money, for example, and they are most times under the control of this.
The spouse.
Yes.
Okay. Now, doctor, as you were busy responding there, I'm reflecting to say sometimes even just, when you get to the clinic, whether be it now in the remote areas, you would of course still be required to have a certain, whether it's $3 or $5 or whatever it is, you still need to forge out that and ensure to enable you to get the service that you would need from the clinic. Now, if you don't have that, then of course that would mean that you may not be assisted because you cannot afford. Okay. Doctor, would you like to expound?
Yes, if I may just say something to that. I must say we are lucky in Namibia because no one gets to be turned away
Okay.
if they cannot afford.
Okay.
They will still be helped. There are measures in place that can ensure that all Namibians are assisted, whether they have money or not.
I'm glad. I'm glad to hear that, and I'm sure it's a relief for somebody else who's probably watching from elsewhere, and they probably don't have money, they don't feel well, but they feel like they need to go to the doctor, but because of a lack of funds, they are holding back. Thank you, doctor, for providing that very critical information. Now, Dr. Iyambo, I'd like to find out from you, beyond the statistics, cervical cancer has ripple effect on families, especially children. Talk to us about the social, emotional impact of this disease that it has on family structures, as well as particularly when mothers are, lost too soon.
Thank you for the question again. Well, we are talking about cervical cancer, which means we are talking about women cancer. And often, if the outcome of this cancer is death, that means someone loses a mother, someone loses a sister, someone loses a wife. But the more people who are affected in this whole situation are usually children. And they are affected both socially, emotionally, and this will mean that their education can also get affected. And sometimes they get so affected that it reflects even in their future when they are grown. Okay? So when we talk of psychological and emotional need, you know, when someone loses their mother, they get into emotional distress. They get into economic hardship. They get educational disparities where some kids cannot go to school, not so because that the education is not there, but sometimes because there's just no one to take care of them. You know how mothers play an important role in someone's life. They are responsible for sending their kids to school, for ensuring that their physical needs are taken care of when they are going to school. And then sometimes they just have this interrelationship problems. They just can't fit in because they feel so isolated. And you know, they just need someone to boost their ego and everything. So it's quite a lot of things that gets affected when someone loses their mother.
Right. Now, Dr. Ndifon, to understand cervical cancer more deeply, we need to explore then the root cause of this deadly disease. Can you briefly explain on the role of human papillomavirus, HPV, and how it contributes then to not only cervical cancer, but also to other forms of cancers?
Yeah, thank you so much. So HPV, or human papillomavirus, as you said, is a sexually transmitted infection. So it is a virus that anybody that has had sex, is having sex, and will have sex is going to be exposed to it at some point or the other. So exposure is one thing, and infection is another thing. Then prolongation of infection is what leads to cervical cancer. So when a sexually active woman or person is exposed to cervical cancer, infection takes place. But 90% of that HPV will be cleared in people that we call immunocompetent. Okay? So there are about 200 HPV types that have been discovered. Out of that 200, 30 of them are sexually transmitted, 30 out of 200. And then about 15 are focused on cervical cancer. So the other lot, they cause, cancers of not just the cervix, but vagina, so we call vaginal cancer, vulval cancer, anal cancer, and just to digress, I know we're talking about women, penile cancer in men. Yes. So you have HPV types like 16, 18, 31, 33, 45, 52, 58. These that I've mentioned now are surrounded in the causation of cervical cancer. Although people have said that maybe about 1% or 2% of cervical cancer is genetic. Yeah. But 98% of cervical cancer is caused by HPV virus. Okay. Yeah.
Now, doctor, I'm sticking with you. Among the many types of HPV, as you rightfully mentioned, 16 and 18 are frequently mentioned. Why are these two considered the most dangerous and significant, and how significant, are they in terms of global cervical cancer cases?
Yeah, thank you so much once again. So like I mentioned, there are about 15, and 16 and 18 is where everybody is hammering, sometimes also 45. 16 causes about 70% of cervical cancer. But this 15 that I mentioned, or even should I say half of that number, are high risk HPV. They are very oncogenic. And that very means that it's like their sole existence is to cause cancer. Okay? They are very, very carcinogenic. That's how we call it. Oncogenic. Once they persist, the likelihood of cancer resulting is very high with the 16 and 18. But when you now take 16 and 18 alone, 16 alone is in 70%. Then maybe you now say the other 20% is contributed by 18, and probably 45, just adding another small percentage on top of that.
Okay.
Yeah.
Sticking with you, doctor, one might ask, right? If a cause of a cervical cancer is preventable, why does cervical cancer remain one of the leading causes of cancer-related deaths among women? What are the key barriers, preventing us from reducing these numbers? Because it's preventable.
Thank you once again. So it is preventable. The key barriers are some of the things we've already addressed, okay? Uneducated young women are most affected, even in that number of cases that are diagnosed. Why? They don't have information. Because they don't have information, they don't seek to screen, okay? They don't seek to screen, that is one. Two, we also talked about barriers. They don't come to us because they are limited by poverty. We don't go to them because infrastructure is not, again, widespread. We don't carry health services to the doorsteps of our communities, all right? And then vaccination is primary prevention. There is a huge gap. According to studies, WHO and the rest, they say that only 75% of countries have any vaccine associated with cervical cancer in country, all right? And then coverage is about 52%. And by coverage, meaning that those that need to get vaccine, that have ever received vaccine, is 52%. When you talk about screening, in sub-Saharan Africa, just about 19% of people have been screened. Although Namibia has done better than that average for sub-Saharan Africa, because Namibia is at 46% or so. But it's still far below what the WHO is asking us to reach, which is 70%. So what are the barriers? Lack of information on the part of our communities, the women, okay? Two, government, for many reasons, funding in particular, because to build a health facility is funding. To buy vaccine is funding. So because of lack of funding, we haven't taken services closest to the people. And even when we do awareness campaign, we are still too much communicating in English, rather than trying to break down information in the language of these people that we already described as not being educated. So what should they do? We need to translate things into their mother tongue,
right?
What they understand, and take it close to them. Make sure that if a woman enters a bank, they goes to a shop in an open market, they can readily pick a leaflet which is shouting in their mother tongue for them to read. And still, if they don't understand, they should be able to pass it on to someone else at home to translate to them. So the major barriers are lack of vaccines, and vaccines are based on funding. Remember that the countries that develop vaccines from scratch to the point where you get a vaccine in a pharmacy shop is a whole lot of funding. And now they don't just give it to you free. You have to buy. And in buying, they are going to make profit. So the buying country also needs a whole lot of money. And there is no way you would then buy this vaccine, say you bring it to a capital, using Windhoek, for example, and you allow it to stay in the storeroom. So if you spend so much money to get these vaccines into the capital, we then need to get it to where every woman or young girl that needs to get vaccinated so that they get it. Otherwise, it will expire and we will lose money. Yeah.
Absolutely. Thank you, Doctor, for responding to that.
Thank you so much.
Doctor, did you want to expound on that?
No, I think she has said.
She has covered
She has
most of
covered
it.
it.
Okay. And now, Dr. Yambo, in response to these challenges that were alluded to by Dr. Ndifon, Namibia has developed a national cervical cancer control program. Could you kindly walk us through in its main goal and how they align then with WHO's global strategy of eliminating cervical cancer?
Thank you, Helene, for the question. So obviously we have realized that we have a problem. We have acknowledged that we are not doing enough. So basically the World Health Organization has a strategy, cervical cancer elimination strategy. It's a 90-70-90 strategy. What does this mean? This means 90% of the girls should be vaccinated by the age of 15.
By the age of 15?
Yes.
Okay.
And 70% of the women should be screened by the age of 35 and 45.
Okay.
And 90% of the women with either precancerous or invasive cancer should be treated promptly, immediately. So the Ministry of Health is trying to align with this strategy so that we are in the same line and we can reach our 2030 vision.
Okay. Doctor, you've mentioned quite, I think it's 3 margins that you've mentioned. The first one being every girl child should be vaccinated by the age of 15. And then by the age of 35, a woman should be screened. Why are we talking about this margin? Why these specific age numbers?
There's quite a number of things that we can look at. Number one is the age at which one is likely to engage into sexual intercourse. So basically, we need to vaccinate our girls
before they become sexually
active. And it has been noted that in our setting, girls are likely to get into sexual intercourse at a much earlier age.
Okay.
And the other thing is that although cancer is known to be a disease of the older people, what we are seeing here is quite different. Most of our patients are diagnosed much earlier, between the age of 30 and 40, and that's what we are seeing in the clinic, and that's what we are dealing with.
Okay.
Yes.
All right. Thank you, Doctor, for speaking to that. But Namibia, I'd like to extend a warm invitation to you to be part of this discussion. As earlier mentioned, we are back on your screen, this time around under the flagship of an OMA's information sharing session, and we are discussing the understanding of cervical cancer, and everything pertaining to it. Now, you too can be part of this discussion by following the conversation on our social media platforms, where we are currently streaming this show live. Now, on Facebook, we are at Ministry of Information and Communications Technology, or alternatively, you can stream us live on our YouTube channel, and our handle there is MICT Namibia. Be part of this discussion and add your contributions on our comment sections on all our social media platforms where we are currently streaming this show live. And back to our discussion in the studio, Dr. Yambo, I'd like to stick with you. It's quite encouraging to note that early detection saves life in as far as cervical cancer is concerned. You've earlier on mentioned as well. We want to know what progress has Namibia made in terms of expanding screening treatment services across the country?
Well, so far, if we look at the current, since 2018, about 138,000 women have been screened so far. The screening services are available at all the primary health care, and the treatment or the management of the pre-cancer lesions, if they are detected are available at all the district hospitals, and the personnel at these hospitals are trained. They initially undergo online training for the theoretical part, and then they are brought in to undergo practical training. So Namibia has done something so far. We can still do much more, and we can still do better.
Okay.
But yeah.
All right. Now, Doctor, there's an observation in the public where if a young, let's say a young girl child goes to the hospital, and unfortunately, because some of them mature so fast and they become sexually active at a tender age, you find that they will find sometimes health professionals at the clinics because they are 13, however, they are sexually active and they are, prone to, when they go to the clinic, they will be asked, oh, you are so young, what are you even doing here? How? Because, the judgment is already there, which is something, which is a narrative that may, push a girl child from wanting to seek for medical attention when needed. What do you say about these health professionals? What needs to be established so that this girl child is not, steered away or scared and be wanting to seek for medical attention when push comes to shove?
Thank you for a very beautiful question. As health professionals, we are supposed to be counselors. We are supposed to be sensitive. We are supposed to be always reminding ourselves of what the definition of health means. The definition of health means it's not just the absence of disease,
Right.
but it's everything: physical, spiritual, emotional, mental, and everything. And we are the ones who are supposed to ensure that we treat our people in the whole aspect of a human being. And now imagine if you are supposed to be the health worker and you are the one who is causing, let me call it stigma already,
Right.
because that is
Yes.
stigmatization.
Yes.
So how do you expect a patient, especially a young girl, to be free with you? So we are supposed to be sensitive. We are supposed to be very mindful of our language, of our action, and just make sure we are welcoming and we are making our people comfortable so that they are encouraged to come back. We shouldn't be the one chasing people away from our facilities. We are supposed to create the whole conducive environment to make sure that our girls especially are comfortable with us, and they will be encouraged to seek for services and be open with us for that matter.
Right. That was on the aspect of, health professionals. But as mothers, we too, we have children and at home. And it's an unfortunate cases where you find that your girl child has really matured so fast and they become sexually active at a tender age. But even at home, sometimes as mothers, I don't know whether it's a thing of cultural norms. Is it because in some cultures it's more like a taboo for me to even approach my mom and want to speak about such, matters? I think as mothers we also need to do better so that we can save our girl child. If the child is already sexually active, so be it. There's nothing we can do but to support them and make sure that they get the right service that they deserve. Right? Away from that, Dr. Yambo, sticking with you, now given the long-term nature of these interventions that you've just earlier on alluded to before I posed to you the question of health professionals, how sustainable is the current national program, and what is the roadmap moving forward beyond 2030?
Well, sustainability can be quite critical.
Right.
Yeah, but we are hopeful that this is going to be sustained because we want to control the disease, cervical cancer in this regard. We want this not to just be a now thing, but a long-term we need to be on the same level with the rest of the world. Obviously, we are an African country. We are a low-income country, as we were recently just classified or reclassified. But I know as Namibians, we can do much more. We can do better. So this campaign is expected to roll out the vaccination around the 14th of August.
Okay.
But this is a multi-decade thing that we are looking at.
Okay.
It's just not now. It's for the current generation. It's for the future generation.
All right. Okay. Doctor, would you like to expound on that?
Yes, thank you so much. Yeah, I want to add that it is sustainable. Remember, we are doing, maybe should I say 2 or 3 things. We are giving information, we are screening, we are supposed to start vaccinating. And when we screen, the chances are that we will pick what we call pre-cancer lesions, pre-cancer, not my word, and then we can treat them very easily. Or if we pick early stage cancer, it's also very easily treatable. But if a woman doesn't present themselves for screening, we are not going to see anything. Okay? Information must be constant. We should begin to talk to medical students or health students, be they nursing or whatever. They should begin to know about cervical cancer prevention strategies. Now we can also carry on with in-service training, you know, and pap smear is so basic.
Yes.
Yeah. Any enrolled and or registered nurse should be able to do pap smear. Just take the sample, because doing the pap smear doesn't mean anything. You take the sample, you send it to the lab, and then they will give us results. When they give us results saying that everything is fine, like right now, if you are HIV negative as a woman and your first pap smear is negative, I think screening is like 5 years if you add it, if you include HPV typing. So you don't screen like every year. It is HIV positive women that we see every year because of their immunodeficiency and higher risk of actually having cervical cancer. So I say that they are sustainable. Now, when we determine the cost of vaccination, and based on our recent classification, like she said, or reclassification, we can target the most important age group amongst the girls and focus there. Because like I said earlier, you can't buy expensive vaccines and leave them in the storeroom.
For what?
For what reason? Then we can mobilize the entire healthcare system to deliver these vaccines to the people that need them, including even vaccinating in schools. And any literate person can understand basic language. Everybody doesn't have to be a doctor. So we can even use teachers to deliver when we do have the vaccines. And I'm saying that it's sustainable.
Okay.
And if I have to add, Dr. Defon has mentioned something very important, the cost. Irrespective of how much this vaccine is costing, it can never compare to the cost of treating cancer.
Absolutely.
Treating cancer is very expensive. And in our country where the whole cost lies on the Ministry of Health, because our patients don't pay. They get screened, they pay whatever they are paying at the clinic. The whole referral system becomes free. When they come to us, we treat them. They pay a small fee of $50 maybe when they are admitted in the ward. But the cost of treating cancer is very expensive. The cost of taking care of someone that we cannot treat anymore is very massive. Yeah. So it's very important for the nation to understand this, and really when this vaccine comes out, we must also come out in number. We are giving the information. It's up to the nation to take this information, act on our information, and take care of their own health. Yes.
Okay. Dr. Defon, now, of course, you know, even though cervical cancer is is mostly, it's a woman, it's a disease that affects women. However, tackling cancer isn't a women-only issue. Now, what role can men play in supporting their partners? This now, whether they are partners, their daughters, their mothers, their sisters, or communities at large, to reduce, HPV transmissions and encourage screening amongst women and, of course, girls.
Yeah, thank you very much for this question that has brought in men. Yes, men are connected to women. It's not all about spouse in the name of wife and girlfriend. And you rightly said it, sisters, aunts, friends, in-laws, grandmother. Yes, this, when we say the women in your life, please, it's not just romantically, okay? There is a greater love, mother, aunt, sister, and the like. And men can do a lot. First, they need to get information. When next you go to your doctor or any doctor or private practitioner, ask them about cervical cancer. Get informed about it. And when you do that, you are empowered to understand that it is preventable. What can you do? You can provide logistical support. The women almost always don't have money, and we, the society, we cost it. They have to depend. So provide money for transportation. Where you can, take them to the place of screening.
Right.
Stand by them, okay?
For emotional
then,
support.
if you are not circumcised, go and get circumcision. Practice safe sex and encourage other men to do same.
Right.
Once you do these things, you have a right standing to campaign amongst other men. And actually, you can fund through charity some of the things to carry this message close to where the men gather. We need to take information to where men cluster, whether it be Shebin, whether it be construction companies. Where do we find our men? We need to get them involved. And when we come to you, don't say, I am a man. Yes, you are a man, no doubt about that. But you are surrounded by women.
Right.
The wife, the girlfriend, the sister, that dear mother, the aunt,
The
daughter, grandmother,
and the friends alike.
even work colleagues. Please get involved. We really want to see you participate.
Thank you so much, Doctor. I love the way, the enthusiasm you shared that with. Indeed, men should rally behind women to ensure that this is a realization. Now, Doctor, earlier on, off the screen, you've mentioned something quite important. We were talking about, what measures need to be taken so that women understand. Now, I think I would like to, let me shift to Dr. Iyambo quickly. We were talking about translation of certain documents in indigenous languages or languages that the people at the grassroots levels or whatever that community understands. Are there perhaps any plans, in translating such important documents such as the pamphlet on cervical cancer, into indigenous languages that is understandable so that we kill the language barrier?
Definitely. Thank you for the question. As a matter of fact, there are already some information that are printed in different Namibian languages. For one, us at the oncology department, we have pamphlets on different cancers written in different languages.
Okay.
Yes, so that is something doable. In fact,
it's already being done, practiced.
Yeah.
Okay, now there is a community in this country, and I'm sure elsewhere in the world, there is a community of the visually impaired and the disabled. I wanted to find out, are there plans or are we already practicing other documents that are translated into Braille? Because that is a community that sometimes is overlooked, and they too need the services that everybody else is getting. Is there such an opportunity perhaps?
A critical question, actually. I am not so sure that it's something we need to find out, something we need to explore, but a very, very critical point you have put there, because we tend to forget our people living with disabilities, especially the visually impaired. Yeah.
Okay. Thank you, Doctor, for that information. Dr. Ndifon, behind the scenes, of course, the laboratories play a vital role in diagnosis and treatment. I wanted to find out from you, of course, the private sector, how does strengthening our laboratory system contribute to the overall effectiveness of cervical cancer prevention and care?
Yeah, thank you once again for that question. So the laboratory system is very important. You know, all these years we just did pap smears, yeah, and the pap smears are really meant to tell us. We knew that HPV causes changes in the cells of the cervix, and the pap smear will pick those changes in the cells, but we didn't know how to identify or diagnose the HPV itself. Now we can do that. But remember, there are a lot of laboratories in the market, but not all of them have the capacity for HPV DNA testing. So, because the private sector is all about business, okay? And you invest money, you expect to make profits. If you don't have the capital, you may not be able to acquire what you need, for example, to do HPV DNA testing. But our laboratories, I think almost all of them are able to do the basic pap smears, while some can go further to do the HPV DNA testing or HPV typing. So if the private sector has more laboratories with the capacity to do the HPV typing, it therefore means that we don't need to wait for too long to get answers to the pap smears that we send. Yes, that's all that I can say for the private sector.
Thank you, Doctor. Is this the same in the public?
Yes, thank you very much. So in the public, we are currently doing the visual inspection and then the pap smear. But the government is working on introducing the HPV DNA testing. As a matter of fact, the machineries are there, both at the Namibian Institute of Pathology as well as the School of Medicine. So it's just a matter of putting methods and everything in place. Yes, because that's actually the recommended method of testing is the HPV DNA.
Thank you, Doctor. Dr. Ndifon, based on recent data, what trends have been observed in HPV? I think you briefly touched on it earlier as when we were discussing the types. In fact, maybe let me rephrase the question to, are we seeing improvement in detection and reporting of cervical cancer?
Okay, thank you for that question. I will say generally that in terms of reporting cervical cancer cases, there should be some improvement. I don't have the baseline. Why do I say there should be some improvement? Before I went into the private, I was working with JAPIGO, the Johns Hopkins program for international education on gynecology and obstetrics, and where I was a technical advisor for cervical cancer prevention. So we did a lot of campaign screening. And like I said earlier, when we screen like that, we are likely to pick up early cancer.
Okay.
And then it is treatable, okay? Or you refer such a patient to the oncologist, like they say, and then they will manage it. But remember, even though we were there campaigning to screen, not everybody responded to come for screening. But in terms of HPV DNA testing, you know, the private sector, they are always ahead. Why? Because they deal with a smaller population.
Right.
Yes, so they've been doing the HPV DNA testing. But for me to give you trends, it means that we have to have a baseline and then do a follow-through, which will be almost like a kind of research. And I don't have that information,
Right.
unfortunately.
Okay, doctor.
Yeah.
But you've touched on an important aspect when you mentioned the HPV DNA test. What exactly does that imply? Because I'm asking now on behalf of a layman, an ordinary Namibian who does not understand what that is. Because ideally what we want to simplify and ensure that information that is disseminating or circulating is information that is understood by even an ordinary Namibian.
Yeah. Okay. Number one, remember microorganisms. We can't see them with the naked eye. So we do intense microscopical studies using certain reagents and chemicals to identify DNA sequencing. And just like you will say, in terms of animals, a sheep and a goat, that DNA sequencing is able to identify type 16, type 18. That 16 and 18 are the years that that typing was confirmed conclusively and say that this is HPV 16. The 16 is a year, but there is also something unique about the genetic code of that HPV 16. And that genetic code for HPV 16 is different from the genetic code for HPV 18 and HPV 45 and all of that, okay? So that is what HPV DNA testing is all about. It goes deep into the molecule of the virus to analyze it. And again, we are unique. Just even look at the three of us here.
Absolutely.
There are so many things that make each of us different from the other.
Right.
And that is what HPV DNA testing tries to do. Generally, there is HPV. But what type of HPV
is it?
Is it?
All right. Thank you, doctor, for simplifying.
Thank you.
Doctor, did you want to expound more on that? Or she covered everything?
She covered everything. I wanted to say something a little bit on the previous question.
Okay.
That of late we have been seeing an improvement of the stages of cervical cancers that we are seeing at oncology. The cases that we discuss in our multidisciplinary team meetings, we have been seeing a number of stage 1s, which before it used to be a flat stage 3 and stage 4.
Right.
But of late, so
because of the awareness, of course.
awareness is improving, and people are taking up responsibility for their own health, and I can only encourage the nation to continue doing so. In fact, if we can be seeing precancerous lesions more, that's what our aim is and our goal is, and we can only hope for a better and healthier Namibia for a disease that is preventable, detectable, and curable. We are not supposed to be dying from it.
Thank you so much, doctor. In fact, that would have been my next question to say, is this disease even curable? Because in most cases, what we see is that it ends in fatalities. Right.
Okay.
Doctor, do you want to expound?
Okay, thank you. Yes, like she said, it ends in fatality because they have presented too late. They have presented too late, and there is nothing much you can do. And when it is really that stage 4, which is generally the final stage, and even that stage 4 is subdivided. So a patient comes where the kidneys are affected, the other parts of the body outside of the cervix and uterus are now affected. So when you now give treatment, even when you do surgery, what they might call debulking, then you now come and add radiotherapy. You damage other healthy cells.
Right.
And then the person cannot survive for long. Yeah. So the screening is so powerful because it helps us to identify the critical pre-cancer stage, which is very easily treatable. And then if we see early stage cancer, for example, they say stage 1 that is confined to the cervix, the cervix can be removed.
Right.
I mean, people have removed breast and they have gone to achieve a lot of things. There is nothing that if they remove, the whole body suddenly dies. You know, if we remove the sick part, then the rest of the body will live longer and achieve more things.
All right.
Yeah.
Thank you, doctor, for that clarity.
Thank you.
Now, we have almost come to the end of our discussion this morning. However, I have a last question that I'd like to pose to both of you, my good doctors. I want to find out from you, accessibility is another concern, especially in remote areas, as earlier on mentioned. Now, earlier on, we were talking about, health, primary health care facilities. But now I want to shift it more to laboratory facilities in remote areas. How are health facilities, and I want you both to answer based on the Dr. Iyambo, based on the state side of things, and Dr. Ndifon on the private side of things. How are health facilities and laboratories working together to improve sample transportations and reduce turnaround times for results, especially in the remote areas we are concerned? Because centrally, we are closer, we live in close proximity to the services that we own, the health care facilities. I will start with Dr. Iyambo, please.
Thank you so much for the question. So obviously for the government, Ministry of Health, the laboratory that does our testing and everything is the Namibian Institute of Pathology. I know the large center is in Windhoek, but they are also based in all the district hospitals, and there are also means of having specimens taken at health centers, even in the remotest of areas, and be transported to the nearest laboratory for testing. So yes, we might not be where we want to be, but there are measures in place. The Namibian Institute of Pathology is located in most of the district, if not all, district hospitals, yes. But there are also means of getting specimens from the clinics and health centers in the remote areas.
Yeah, thank you so much for that question. And just to add, I can actually speak only for Windhoek. Most laboratories collaborate with private doctors, and they actually send people to go around and pick samples every day, as long as the samples are there. But common sense tells us that Namibia being a very vast country, so let's say, for example, Rundu, where I had worked for 6 years, there might be laboratories there that are also going to private sector to pick samples. But if the labs there are not able to work on the samples because they lack the capacity, it therefore means they also have to transport it all the way down to the capital, and in very rare cases, samples go to South Africa. So all of this, they add to the long waiting time to get back results.
My ladies, my good doctors, we have come to the end of our discussion this morning. However, before I let you go, I'd like you both to please give your final remarks. Speaking to women, especially the girl child, but not only women in the girl child, because we did mention earlier on here that men, as much as this disease, affects women, men live around women. They are surrounded by women, and they too are part of this discussion. Dr. Yambo, I start with you.
Thank you. To close off, I would say we must remember that cancer in its earliest stage does not give any symptoms. Hence, it's very important for us to practice prevention and screening for early detection. Let's be supportive of one another, our family members, our neighbors, our church, so that we achieve our goal of eliminating cervical cancer, having at least less than 4 cases recorded.
Right.
It's doable. We can do it.
Okay. Dr. Ndefo?
Yeah, thank you so much. I want to encourage the women. A lot of women, including some of the ones that we say that are not educated, they have smartphones. What are you doing with it? Search whatever you can search about cervical cancer. If you don't understand, go to the nearest health facility for explanation. Go to the nearest doctor. Go to your doctor for further explanation. 2, let us not propagate falsehood around vaccines. We paid dearly during COVID. We don't want to keep paying dearly for cervical cancer. And we had talked about who suffers the most, children. Thirdly, I want to speak to my co-healthcare workers, private or public. When you see a woman that you know has the right to be sexually active, can you please ask them if they have screened for cervical cancer? Simple. Meme, do you know what is pap smear? Have you done pap smear? And if the answer is in the negative, I believe most doctors should be able to offer a pap smear. That is the only way we can pick pre-cancer stages. And like my colleague said earlier, we don't want cancer. That's why we say cervical cancer prevention. To the point that one day, a doctor will not know what cancer looks like because we have eliminated it. Thank you.
Thank you so much, Doctor. Thank you so much to the both of you doctors for taking time out of your busy schedules. I know that you run important offices and that you have patients probably waiting for you to see them, but because you saw the need to come and educate the Namibian nation on the importance of understanding cervical cancer, you made it time and you made time out to come and educate us on the GIC platform. We thank you so much for coming here to see us this morning and speak to us. And please continue doing the important and playing the important role that you are playing in the health sector, both private and state. We thank you so much for the important work that you do.
Thank you very much, Heleni. And we wish to thank the government of Namibia and the Minister of Health for giving us this opportunity.
Right. Namibia, that concludes our brief discussion for this morning. Please do join us again next time when we bring you another fruitful discussion here at the GIC. From myself, Heleni Felepa-Samunyela, and the entire GIC production crew. Until next time, take care.